Hello guys, it's your dream doctor here. Let's discuss a new topic which is odontogenic tumors. Okay, what do you mean by odontogenic? Odonto means tooth, genic means forming. So, it is a tumor arising from tooth forming tissues, that is the odontogenic tumors. So, odontogenic neoplasm are complex group of lesions derived from the dental formative tissues or their remnants. Okay, so these neoplasm will resemble various tissues which are found during the odontogenesis or the tooth formative stages. It can be arising from enamel organ, dental lamina, dental follicles, dental sacs, etc. Odontogenic tumors can be classified into benign and malignant. In benign, according to the tissue of origin, it can be epithelial, mesenchymal and mixed, where the epithelial a group of neoplasm, there is all the neoplasms are arising from the epithelium in origin, and mesenchymal, it is from the connective tissue, or it's a ectomesenchymal in origin. In mixed, where the tumor components is arising from both epithelial and mesenchymal or the ectomesenchymal in origin. Examples of epithelial benign odontogenic neoplasm are ameloblastoma. Ameloblastoma can be further classified into solid or multicystic, unicystic, then extraosseous or peripheral, and metastasizing ameloblastoma. Then squamous odontogenic tumors, CEOT and AOT. And in mesenchyme, it is odontogenic fibroma, odontogenic myxoma, cementoblastoma, cemento-ossifying fibroma. And coming to the mixed, it's ameloblastic fibroma, then odontoma, compound and complexes there, then dendinogenic ghost cell tumor, and primordial odontogenic tumors. Okay, in coming, let's see malignant lesions. It is the epithelial origin, there is epithelial origin, ectomesenchymal origin and mixed, where it is ectomesenchymal and epithelial. Example of ectomesenchymal and epithelial, which is the mixed tumor, is odontogenic carcinosarcomas, and example for ectomesenchymal origin is ameloblastic fibrosarcoma. Ameloblastoma. Ameloblastoma is considered as the true benign neoplasm of enamel organ. According to Robinson, it is a tumor that is usually unicentric, non-functional, intermittent in growth, and anatomically benign and clinically persistent. So, whenever the definition of ameloblastoma is asked, you have to write, according to Robinson, a tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. Broca gave the first detailed description of this tumor, and Malays coined the term adamantinoma. But the term adamantinoma represents the formation of hard tissue. But there is no hard tissue formation, so the name adamantinoma is no longer relevant. Then Gallups coined the term ameloblastoma, and later Churchill propounded the name ameloblastoma. Why the term ameloblastoma? Which means the neoplasm, in this neoplasm the cells resembles ameloblast. So it's given the name ameloblastoma, but is that true ameloblast? No, it's not a true ameloblast, because they resembles ameloblast in morphology, but functionally they are not fully differentiated to produce enamel as like that of ameloblast. So ameloblastoma, the term is also a misnomer. Among all the odontogenic tumors, it's the second most common neoplasm of odontogenic origin, but the first place is for the odontoma. Etiology of the ameloblastoma. The sources of origin are dental lamina remnants, reduced enamel epithelium, odontogenics is like dentigenesis, basal cells of the oral epithelium, and Hudwig's root sheath. And the molecular factors are BRF V600E mutation, where the V600 gene, the valine substitutes the glutamic acid at the 600th position. So it's a substitution of glutamic acid at the 600th position of the gene by valine, and it can be due to SMO gene mutation. Then the triggering factors can be trauma, chronic irritation, inflammation, etc. So it can be derived from various epithelial sources in the dental apparatus, but the actual stimulus for its initiation is unknown. Most commonly arises from cell rest of enamel organ, either the remnants of dental lamina or the remnants of Herdwick's root sheath. And if there is a disturbance in the developing enamel organ, epithelium of an odontogenic cyst like dentigerous cyst, then cells of that development of ameloblastoma from odontogenic cyst like dentigerous cyst is called mural proliferation, that we can deal when discussing the when we can discuss dentigerous cyst. Okay. Then HPV virus, mainly HPV-16 virus. Then nutritional and health status of the patient also modifies this factor. These all are the etiological factors of ameloblastoma. Now moving on to the clinical features and radiological features of ameloblastoma. In clinical features, there is painless swelling or expansion of the jaw, which will result in facial asymmetry. See, this person is having a painless swelling and expansion of the jaw, and this swelling is painless, but the patient is presented with facial asymmetry. Then there is tooth displacement or malocclusion. There is loose teeth or teeth may be present, and paresthesia may be experienced. Okay, these are the clinical features. And coming on to the radiological features, there is main thing is radiolucency. Multilocular radiolucencies are seen. It can be of two types. It can be of soap bubble appearance or honeycomb appearance. When the locules are even in shape, it will represent as honeycomb appearance, but if the locules are uneven in shape, it represents as soap bubble. Then there is well defined corticated borders is present, then may be associated with impacted tooth. Root resorption of the adjacent tooth can be seen, then perforation of cortical bone can be seen. These are the features regarding ameloblastoma clinically as well as radiologically. Now we can move on to the histopathological features of ameloblastoma. There are 6 histopathological subtypes of ameloblastoma, that is follicular type, plexiform type, acanthomatous, granular, basal cell and desmoplastic. The follicular variety is the most common and it is showing the high rate of recurrence. The lesion usually shows the mixture of subtypes, but the predominant form is considered for the classification. So coming on to the follicular type, it's the most common type and high in recurrence rate. Neoplastic epithelial component proliferates as disconnected islands, strands or cords of varying shapes. The connective tissue is fibrous and only supportive to the neoplastic epithelial component. And the peripheral cells are tall columnar, and the innermost cells is stellate reticulum like cells, and it have a palisading arrangement and hyperchromatic nuclei is present. The cells are tall columnar, and the main thing is there is reversal of polarity seen. There can be cyst formation also seen, where in plexiform type the tumor cells are arranged in a network of interconnected strands, and which strands have a peripheral columnar cells and stellate reticulum like cells in the center. Sometimes double rows of peripheral cells are lined up back to back, and the central cells are much less prominent in plexiform type than the follicular type, and cystic generation may be seen in the connective tissue and not in the stellate reticulum, where in follicular type it was seen in the stellate reticulum region and not in the connective tissue region. Okay. Coming to the acanthomatous ameloblastoma, in this histological variant, the odontogenic epithelial cells arise in the form of follicles with peripheral ameloblast-like cells, which means the tall columnar cells, and the central stellate reticulum-like cells. In some of the follicles, the central cells undergo squamous metaplasia to form squamous cells and may show evidence of keratinization. Most commonly seen in peripheral or extraosseous ameloblastoma. Next variety is the granular variety, and this is a rare histological variant of ameloblastoma where the central stellate reticulum like cells of ameloblastoma shows extensive granular cell transformation. These granular cells are large cells with abundant granular eosinophilic cytoplasm and pycnotic nucleus. The granules are identified as numerous lysosomes accumulated in the cytoplasm attribute to the degenerative changes. Sometimes these changes may be so extensive that the peripheral columnar cells may also be replaced by the granular cells. And basal cell variety, this is the rarest histological variant of ameloblastoma. In this type of arrangement of proliferating odontogenic epithelial cells in a follicular pattern with peripheral cuboidal or low columnar with a less evidence of palisading, the central cells of the follicle are typically basaloid. What do you mean by basaloid? Means the basal cell-like appearance, which resembles the tumor cells of the basal cell carcinoma. Basaloid cells have hyperchromatic nuclei almost filling the cell with scanty cytoplasm. However, some follicles may show classic features of conventional ameloblastomatous follicle. Next variety is the desmoplastic variety. In this, the histological variant, the epithelial components have a tendency to grow in very thin strands and cords, which is characterized by extensive stromal collagenization or desmoplasia surrounding irregular islands of odontogenic epithelium. The proliferating odontogenic tumor islands will be compressed in highly collagenized stroma, may show as a point stellate or kite-like appearance, which means nothing. The follicles will be seen as very thin cords or strands due to the compression caused by the highly collagenized connective tissue. That is the desmoplasia. That's why the name it is desmoplastic variant. Okay, now we can move on to Vicker and Garland criteria for ameloblastoma. That is palisaded arrangement of the basal cell, reversal of polarity, and presence of stellate reticulum-like cells. Okay, this is the Vicker and Garland's criteria. The presence of central stellate reticulum-like cells. You can appreciate there is stellate reticulum-like cells will be there, and there is presence of tall columnar cells, and this is the basement membrane, and there is a reversal of polarity. This nucleus is away from this basement membrane, and there is a subnuclear vacuole formation. You can appreciate in here it will be eosinophilic in nature, but this will be plain. That is, the subnuclear vacuole is present. These are the criteria called as Vickers and Garland's criteria for ameloblastoma. Now the treatment and management of ameloblastoma. First thing is conservative surgery, then radical surgery, then reconstruction, and medical therapy, and long-term follow-up. Okay, conservative therapy, it's enucleation, but the recurrence rate is very high, so we will consider en bloc resection, where in that, if this is considered, this is the tumor, we will remove this tumor with a portion of unaffected bone for reducing the chance of recurrence. That is called en bloc resection. So thanks for watching. I